The broadcast is now starting. All attendees are in listen-only mode.
Good morning. Welcome to the CAFC Patient Safety Collaborative. My name is Lisa Stromquist, and I'm the National Coordinator for Quality and Patient Safety at the Canadian Association of Pediatric Health Centres. So before we begin today's webinar program, I'm just going to go through a few of our usual instructions, and just to remind everybody that all of the lines are muted so that we don't have any background noise for our presenters. And as always, we'll take your questions at various times throughout the webinar, so please just type your questions and comments into the question pane as you think of them. That way we're all ready to go when the time comes for our panelists. This session is being recorded, and it will be posted up here on the CAFC's Knowledge Exchange Network, along with any other resources or documents that are provided to me by our presenters. It usually takes a couple of days to get that information up, but you will receive an automated message from the system with the direct link to that page. Although you can always use the search function within the CAN to find any of this information as well. Another aspect of our Knowledge Exchange Network, it does provide for comments on each of the pages. So if you want to continue the conversation or you want to add some more information, I do encourage you to post anything there. Become a registered user and post your comments and information there. So today's session, Patient Safety Culture, a Story in 3 Acts, will be moderated by Darlene Bolivar. She's the Director of Patient Safety and Risk at the IWK Health Centre and Chair of the CAFC Patient Safety Collaborative. So Darlene's been in her current role at the IWK for the past 8 years and has been with the IWK for 15 years. She has a Bachelor of Nursing from Dalhousie and a Master's of Adult Education from St. FX. She's been involved as a primary investigator on many IWK research initiatives, national and international, and has collaborated on many publications. And we have 3 other speakers who will share their perspectives on building a culture of patient safety. So Dr. Trey Coffey. And Dr. Coffey was inspired to pursue quality and safety during her residency at Seattle Children's Hospital and brought this passion to sick kids in the Division of Pediatric Medicine in 2005. In 2012, Trey assumed the roles of Medical Officer for Patient Safety at Sick Kids, Associate Director of the University of Toronto Centre for Quality Improvement and Patient Safety, and Executive Member of the Pediatric International Patient Safety and Quality Community. With these combined roles, Trey works to bring the latest and best methods in improving safety to sick kids and also to facilitate the uptake and spread of pediatric patient safety innovations provincially and nationally. We also welcome Dr. Andrew Link, who is Associate VP of Medicine and Chief of Pediatrics at the Cape Breton District Health Authority in Sydney, Nova Scotia. And he's a past president of the Canadian Pediatric Society. Dr. Link received his medical degree from the Dalhousie Faculty of Medicine. And he became the president of CPS after serving as chair of the Society's Advocacy Committee for 10 years. Dr. Link was the founding medical director of Cape Breton District Health Authority high school-based youth health centers and has been a consultant on a number of community-based projects. And we also welcome Dr. Michael Apcon, who is a pediatric specialist and physician executive, having held senior leadership roles at several top academic hospitals. He has served as president and CEO of Sick Kids since January 2014. And prior to coming to Sick Kids, Dr. Apcon was Chief Medical Officer for the Children's Hospital of Philadelphia and Executive Director leading Yale New Haven Children's Hospital. He's currently a Professor of Pediatrics at the University of Toronto and has held faculty positions at University of Pennsylvania, Yale School of Medicine, and Yale School of Management. As a healthcare executive, Dr. Apcon has led systems development and improvement to drive high quality and safe care, improve clinical operations, and promote an integrated approach to healthcare across a continuum of services. So now it's my pleasure to hand the microphone over to Darlene Bolivar.
Good morning or good afternoon and welcome. And as Lisa said, I'm doing a bit of a dual role today because I am the the chair of the Patient Safety Collaborative, and I will be facilitating and moderating the group today, but I do have a bit of a role in participating as well. So I'm just going to talk a little bit about the background of this, and Lisa's going to manage my slides for me. So it's my pleasure to welcome everybody online to the session today, Patient Safety Culture, A Story in 3 Acts. So basically what we're going to talk about today, we're going to provide you with an overview of the feedback from the CAPC annual conference this year that took place in October in Quebec City. We're just going to do a bit of an overview of what you said. We're going to, Act 1 is going to be the Convert It, and that is going to be overviewed by Dr. Trey Coffey. The Lone Voice will be Act 2, and that will be Dr. Andrew Link. And then the CEO's perspective by Michael. And then we're going to talk and have some conversation with how we're going to work together and what's next. So we want this to be a very interactive discussion at the end of our 3 acts. So here's what was said at the CAPC session this year in 2015. You told us that we need to establish a culture of patient safety across the continuum of care. So not just focusing on acute care or maybe large pediatric hospitals, but across the entire continuum. We need to take a focus on preventing all harm. Focusing on a single intervention doesn't have a broad enough impact. So although we don't want to necessarily move away from doing that, we need to focus on harm broader than that. And we need to understand the risks through the sharing of accurate and timely data. So we need to go back and really ground and root into look at using the data that's collected across the continuum, what we know about harm, and really grounding ourselves in the data. So can we be successful at numbers 2 and 3, the focusing on all risk and grounding in the data, if we don't have a really strong patient safety culture? And that's going to be one of the questions that we're going to be trying to grapple with as we go through the session today. And we want to get back to basics. So what we know about the basics is, you know, we need to be focused on high reliability and what we learn and know from other highly reliable organizations, such as aviation, which is where safety culture and just culture started, but also beyond that into more complex situations that doesn't have a sterile aspect to it. And what I mean by a sterile aspect is it's great that we learn what we know about checklists and standardization through aviation, but the context of how that gets delivered is very different. When you think of a pilot and a co-pilot behind a locked door, not with no interruptions allowed, going through the checklist, and how that is, kind of the polar opposite of sometimes what's going on in healthcare with all of the interruptions and all of the distractions, and how do we stay focused on the task at hand and be highly reliable. We talk about, consistency, fairness, and justice in our application of any kind of interventions or investigations around interventions, and how do we get those principles embedded in everything we do. How do we look at speaking up and creating an environment where everybody feels safe and free to speak up because they know that the investigation or the follow-up and follow-through is going to be consistent, fair, and just. How do we get back to looking at our critical analysis that's focused on facts and stop chatter when an incident or something happens, and how do we build that culture that keeps us focused on facts, focused on data, and not on supposition before we actually get into the systems approach and the systematic reviews of things? And how do we garner and learn everything we need to make a safer organization, make a safer system, but how do we share those across organizations organizations and across provinces and across the continuum at a national level to make sure that we really are building that culture that is highly reliable, consistent, fair, just, where people are free to speak up, where we have a consistent analytical process that's focused on facts and a true systems approach across all the continuum. And then finally, when we talk about back to basics, Lisa, can you advance the next slide, please? Sorry, there. So this is just kind of a little history lesson that I'm sure everyone on the line certainly knows, and this is about back to basics from from a just culture lens. So if you look at the red blame culture on the right-hand side of your screen, that's where we were probably in healthcare 15 years ago, and that's where some of us still sit. So in a blaming culture, the culture is founded on blame and discipline of individuals, and they don't take the complexity of the systems into account. It's more about the person at the the front end or the pointy end, if you remember James Reason's Swiss cheese model. And it's finding personal fault associated with the cause of any incident. So, 15 years ago, that's kind of where we were sitting in healthcare. And then the pendulum swung, based on the IOM report and some other reports that came out of that, the adverse event study, and then the Canadian Pediatric adverse event study, which many of you on the line may have been part of, that was took place in 2010. And we really tried to set the context of adverse events in pediatric healthcare and pediatric organizations and how they were very similar to what was happening in the adult world, and how we needed to move into a no blame or a blame-free culture. And that was a culture that was founded in using events as opportunities to learn without placing that personal blame or fault that we were trying to move away from in a blame-worthy culture or a blame culture. But what we're finding now is if we go strictly to a no blame or a no name, no shame culture, there's no clear accountability implied. So now this pendulum is swinging back into a fair and a just culture where we look at still having a blame-free culture where when the system is really truly at fault, but we also need to have the accountability built into that culture. So a fair and just culture is a culture that's founded on justice and process improvement. It's finding the balance between open learning and the need to hold individuals accountable for their choices in providing care. And it's acknowledging that removing blame does not absolve individuals or organizations from the accountability. It implies that we are going to place that accountability in the right places and fix what needs to be fixed. So that's really just an introduction of providing a brief, broad overview of getting us back into the basics. And now we're certainly going to move into Act 1.
Hey, good morning, everybody. It's a pleasure to be back to continue this great discussion we've been having about safety throughout the year. I want to start with something that's hot off the presses that's really a major validation for how CAFC has distilled everyone's input into a focus on culture. This report is from a panel of global patient safety thought leaders and was just released a couple of weeks ago. I'll pause to do a very Canadian thing and give a shout out to the Canadian co-chair, Kaveh Shujanya. If you were on the webinar that was the first one in this series, you'll recall that Kaveh talked about how progress has been too slow in the first 15 years of the patient safety movement. And so now let's talk about what the recommendations are for going forward. So the first step is incredibly simple, but simple doesn't necessarily mean easy. It has to start with the acknowledgement that we have to change our approach. And as we all know, change represents a loss of what's familiar and comfortable, and it puts us all into a zone of discomfort, even the converted and the safety advocates. And here's the first recommendation from the report. It's that leaders need to establish and sustain a safety culture. And I think the language here is really important. It's not just that they need to support a safety culture. It assumes that we don't yet have this culture and that specific steps need to be taken to establish it. So what exactly is it urging leaders to do? I think that we now can answer this question. We have great information from safer industries who've distilled specific tools and behaviors into what you could call a safety culture playbook, or what the Solutions for Patient Safety Collaborative calls culture work. And these are concrete, specific steps that folks in positions like Mike's are able to speak to. So what does that mean for us, the converted? Patient safety leaders, we tend to have expertise, we have a lot of passion, we have clinical credibility, hopefully, tools that allow us to lead through influence more than through authority. But the mandate for the next era of safety is really aimed squarely at leadership. And I think that the impact of that on us as safety advocates is that the impact of our work is so much greater when we're working in close collaboration with senior leadership. And of course, I'm talking about these categories like they're mutually exclusive, and they're not. We, as you can tell from Mike's bio, we have someone who, as our CEO, was a deep patient safety expert before becoming a health executive. And in someone like Andrew's case, one might be the frontline staff, the converted, and the senior leader all at the same time. But for the purposes of this discussion, I'm treating these roles as distinct. So what I'll now do is share a couple of quick observations that I've made specific to what it looks like from my vantage point when an organization embarks on this deliberate action to do things differently for patient safety, focusing on culture. One of the first steps is to try to establish a more informed culture. So that means that leaders and managers in all areas have the basic patient safety knowledge to properly spot, analyze, and address safety problems. Many of the folks in these positions have kind of inherited responsibility for safety without having been provided the requisite professional development opportunities. And there's also just a general under-recognition that there's a science to patient safety. So sometimes people just don't know what they don't know. They may not know that most safety events are underreported. They may not have the tools to analyze events or to understand the complexities of human error. They may not realize that there's a hierarchy of reliability of interventions, with requests to be more vigilant at the bottom and redesign at the top. And I think our organization is not alone in having historically kept safety expertise somewhat confined to a small group of individuals. I know that I've logged hundreds of hours teaching patient safety, but it's typically been to other converted types who are coming to get that knowledge so that they can go and lead safety in other organizations. So when we embark on this culture change, the executive creates a sense of urgency around safety, and that quickly translates into people in the organization recognizing a need for more knowledge. And they really go into a pull mode, asking for this knowledge, inviting us to rounds and meetings, looking to come to seminars and symposia. Of course, there will come a point when those early adopters have all gone through, and there will be a need for a push mode where there will be mandatory learning. But it's quite impressive to see the degree to which this sense of urgency puts people into being, activated learners and looking for this knowledge. The next observation I want to share relates to what Darlene spoke about very well, which is just culture. And my feeling here is that even if you're the converted and you think that you understand this very well, I'm not sure that we all do. And I know that I thought I understood it well until I had an opportunity to get some deeper learning in the area and appreciate the complexities a little bit more. Many events actually represent a combination of a bunch of little events. For example, you might have a combination of an unconscious slip type human error that you're supposed to console with also some subtle conscious behavioral choices that we should be coaching. And the other really tricky thing here is that when you uncover an illegal normal, so you identify that an individual is not following the right safety behavior, say like checking patient ID, but it passes that substitution test where you speak with other individuals in the area and you learn that everybody's kind of behaving or making the wrong behavioral choice in the same way. It brings to light that there's this obligation of the manager to have more responsibility there. So in the old days, it was okay to have the big binder and say the policy's there, the staff are accountable to follow it. And in the new way of doing business, it's critically important for those frontline leaders to make the expectations crystal clear and to have them continually reinforced. And I think that can be a bit overwhelming sometimes for managers when we start this work, because not all of them have been equipped with deep learning on the principles and tools of just culture. And the last aspect I want to speak to about the safety culture journey is resilience. And this word means a few different things. One is that we, as an organization, have the flexibility and tools to bounce back quickly from errors and minimize harm that can occur when one error can turn into a cascade of errors. Another meaning is that staff are personally resilient. They come to work healthy and rested and engaged so they can make the right choices and be effective communicators and team members. An important component of this is how we deal with staff involved in errors. And this is sometimes referred to as second victims, with the idea that just like patients, nobody comes to work thinking that this is going to happen to them today. And in fact, a lot of our staff are sort of like superheroes who are constantly intervening in potential errors. Well, when we launched our revamped safety event review process in the summer, there was a bizarre twist of ironic timing, and I found myself actually an involved provider in one of our events. Almost 15 years to the day since the last time I'd been involved in a serious event. And I learned so much from this. First of all, I think that I had been very naive and really just plain wrong in thinking that in the new era, things are easier. In the old days, we didn't deal with these formally, but in fact, that made the trauma of the event much more limited because things were kind of hush-hush and they weren't really surfaced. In the new way of doing things so formally and with such a great spotlight on safety events, the unintended consequence of that is that it amplifies the effect on staff by orders of magnitude. And with our strict attention to proper procedures with root cause analysis, the ability to speak informally to colleagues and debrief, which is one of our most important coping strategies as health professionals, is taken away from us. And lastly, what I learned is that we're kidding ourselves if we think we're past shame and blame. We have dealt very well with the blame piece, I feel. We really are focusing on systems, but what I'm learning from my experience and that of many colleagues is that healthcare professionals don't need the blame to feel the shame. We're still quite hardwired to experience it as a personal failure, even though we know it's a systems problem cognitively. And that can apply to 10, 20, or even 30 individuals involved in some of these big complex events. So my message for you all is, if you feel that you've been attentive to this, consider being more so. And if you're in the majority of hospitals like ours who don't yet have a robust program for supporting second victims, this is another important thing to start working on. So here we are back where Kaveh left us, quoting Carl Weick in that first webinar, that we've moved through the phases of new knowledge. We started with the naive exuberance, kind of a simplistic view of how to tackle culture and teamwork and communication. And after a period of confusing complexity, we're re-emerging with back to basics, as Darlene put it. And we now know more about specifically what we need to do to establish that safety culture. And I'll close by saying to my converted friends out there that despite this being everyone's business now, we're more critical than ever. There's many, many tasks that need to be carried out, and there's always a risk of people getting a little lost in the weeds. So it's really important that we're continually looking to make sure that all of everybody's efforts are contributing to that end goal of reducing preventable harm. And with that, I look forward to hearing from Andrew.
Thanks, Trey. We're just passing the microphone over to Andrew.
Good morning, everybody. Andrew Link from Cape Breton, and I'm going to give a perspective and build upon a little bit of what Darlene and Trey have talked about from regional centers. So just to give you a little perspective, I've practiced pediatrics for about 25 years now in Cape Breton, and we have a population that we serve about 120,000 in our catchment area. We do about 1,000 deliveries a year. We do have a NICU here with a neonatologist, and there's 4 consultant pediatricians. We do a lot of oncology here in conjunction with the Children's Hospital in Halifax, and obviously anything that comes through the door in the emergency room that's critical, kids who are critically ill or sick or injured, we look after those. We either keep or stabilize and transport to Halifax, which is about just over 1 hour helicopter flight and transportation if we have to, and that's if the weather is okay. And the weather isn't always okay here, so sometimes we're on our own. This is just a picture outside of Pediatric, Nova Scotia and Cape Breton, where Alexander Graham Bell lived. So we're going to go on a little journey here. This is the hospital that I work at, which is the Cape Breton Regional Hospital in Sydney. But we also have quite a few smaller community hospitals like this one that's also in Pediatric that can have children coming in who are injured or in house fires or little babies with high fevers who could be septic, and we have to manage all of that too as well. So some of the issues, safety issues in community and rural and regional hospitals such as my own, one of the pros is that usually we have minimal staff turnover and there's not a lot of students around, which we do have students and residents coming around, but for the most part the consultants, the pediatricians are very involved with the patients. We know the nurses well and they know us quite well, which I think for better for worse probably is a good thing. I know when I worked and I've been a learner in a teaching hospital, for the nursing staff it can be quite a challenge because every new month there's a new senior resident or junior resident coming through, and obviously a big thing about culture is communications and trust and counting on each other, and that's a little harder sometimes in the teaching hospital, but we don't have that disadvantage. The difficulties may be is that some of our community hospitals clearly, where they have us by phone, they don't have a pediatrician close by. So some of our hospitals are 2 or 3 hours away, and we have winter weather to deal with sometimes. We aren't in-house all the time, so we have children who might be on a ventilator or maybe as an inpatient. So the pediatricians, we live close by, but we're not necessarily in-house. So that can sometimes be, you have to be prepared for that. We talked about the weather. So if we have somebody who's sick here and you're thinking that you might want to transfer them, you really have to plan and don't let them get into extremists before you're going to go. We're on call for the whole weekend, so from Friday morning to Monday morning for 72 hours. So as specialists, especially if things are busy and you're getting called at 3 in the morning on Monday morning to go to a C-section for a sick baby and you've been up all week, you have to be quite aware of your own fatigue levels and maybe sometimes call on a colleague to help you out. And that's a little bit different than the bigger hospitals. Our patient safety officers, and we have one here who's wonderful, but she comes from the adult world. So in terms of understanding some of the issues around the NICUs and the newborns and pediatric issues, that may be new for her, and it is new for her, so we may not have that close contact with our patient safety officers in terms of having intimate knowledge of how things work as you may if you're in a children's hospital or in a children's institution. The other thing is that many of the physicians are paid, rather than in the academic centers where they're on a salary, here they're fee for service. So if the quality and safety meetings are at 10 o'clock in the morning and people have to leave their office to do unpaid work, I'm not saying that they won't do it, but sometimes to have good physician engagement, you have to be cognizant of how people are remunerated and whether they're the only ones in the room who are giving up their volunteering free time or not. And people may roll their eyes a little bit, but having been a VP medicine here and trying to get people involved, I've really encouraged our quality and safety folks to make sure that the times are physician-friendly as best as we can, and people have been quite accommodating to that, and that has made a difference. In terms of some of the things I can think about in the past, we've had asphyxiated newborns in rural hospitals during the middle of a snowstorm, and I can remember having a friend having to take me in his big SUV to get there because our ambulance couldn't get there. We had recent cases where we thought we were listening to the fetal heart rate was in fact the maternal heart rate, and that ran into some trouble with us. We've had another child came in during the holidays once who was had shaken infant syndrome. We didn't recognize that initially, and because there was frequent handover every 24 to 36 hours because of the holidays, that got missed. Unfortunately, we've had issues with hospital-acquired infections, especially C. difficile and other nosocomial infections, which we've actually got a handle on, and we've had Michael Gardam down from Toronto to help us out, and we post our hand washing rates so all the parents and everybody can see them and the staff can see them, and we've really got that under much better control. As I said, sometimes we can't always transfer very ill or injured children because of the weather and the helicopters down, so we have to rely on our colleagues in Halifax over the phone to help us out. I can also remember a time when we had the wrong chemotherapy given to a child, luckily without harm, but you could see in a system area where that broke down, and also on the ward where the junior nurse, for whatever reason, did not feel comfortable speaking up to the senior nurse who had okayed it, and they were supposed to double check it. This was quite a while ago, I must say, but again, culture, as Trey has said, is very important. And I think the other thing that I've learned, I was chief of pediatrics here on and off for about 10 years until I became the VP medicine not so long ago. I honestly did not know what a required organizational practice or an ROP was. No one had sat down to teach us that, and usually when the accreditors were coming, everybody seemed to get quite busy. That is our nursing managers and staff, but we just thought we were doing it for accreditation. So I would take Trey's point. I think when it comes to culture, I think part of a safety culture is the deliberative and thoughtful training of not just nurses and patient safety officers and other health-allied professionals, but also physicians. And that doesn't just include in the academic centers. That includes how do we do that and share that the whole science and the thought behind safety, patient safety and culture with our chiefs of pediatrics in all of the regional areas. As many of you may or may not know, that 68% of all the pediatric inpatient admissions across the country are actually to community hospitals and not academic centers. And for serious preventable adverse events, and by that I mean either death, disability, or prolonged stay or admission, and this was from the Canadian Pediatric Adverse Event Study that Trey had a part in, I know, and maybe others on the line. It was 2% in community hospitals, 4% in children's hospitals. And in community hospitals, most of these involved diagnostic errors in clinical care, and mostly in our ERs, which in our case are staffed by family physicians who've done some who've done a little extra training in ER, but not necessarily have a great grounding in pediatrics, and also in our labor and delivery areas. So those may be the two more higher risk areas, and it would make sense to me. And again, going back to what Trey has talked about and Darlene has alluded to, are the whole idea of high reliability teams. And one thing I think I've learned is that they have to be co-led by both the nursing lead and the physician lead, clear communications. We need the training not only in the safety, patient safety and science and implementation science, but team training is a good idea as well, especially where people aren't used to working in teams, or if there are hierarchies that are causing issues. I think the issue that Trey talked about, situational awareness and mitigation, is very important in the regional areas where we don't have necessarily access to in-house physicians all the time, and also to when children go bad quickly, while we can stabilize, we need to try to get there before they crash, as it were. And so it's very important for that to happen. I know in our pediatric meetings, and I'm hoping in our other meetings across the hospital, I've asked that quality and safety be on the permanent agenda item, and that be chatted about, and that we're just getting our M&I rounds that are going on. I think, as Darlene had talked about, the importance of speaking up, and to know that you can speak up and still be loyal. Colin Powell, who wrote a leadership book, once called these loyal dissenters, and I think we should encourage that, especially from our junior people, even student nurses, that they need to know if something doesn't make sense or if it's wrong. We, as leaders, we need to go and give them permission and expect them to do that, and to be receptive to do that. Again, something that I've learned in over the last 5 years or so, that ROPs aren't just for accreditors, they're actually for patients. One idea that, as I was preparing for this chat, and the one that Trey and Darlene and I gave in Quebec City at the CAFC annual meeting back in October, was how in the regions can we perhaps have a network where we can share lessons in terms of improving safety culture, sharing lessons about when things go wrong, and how to mitigate and how to be aware. So we are high reliability teams as well, and perhaps in conjunction with our colleagues at our own academic pediatric centers. But I think there's a great deal of potential that could be done, and using CAPC as a coordinator or facilitator for this across the country, smaller centers could do this. Because as I said, a lot of sick children come through their centers, and we shouldn't take for granted that things are up to scratch there. Here's another great book. Many of you may have seen this. If you haven't read it, I'd highly recommend it, by Peter Pronovost from down in Baltimore, who talked about in 90% of serious patient events, somebody knew something was up, but they didn't say anything, or they spoke up and it was ignored. And I think that's something that we really have to work hard against. I'm just saying, one other issue, I guess, in safety culture in community hospitals, the high-risk areas are young infants in the ER. We have to make sure that our ERPs have training in resuscitation as well as our delivery staff. And again, that's where system leaders can help out to make sure that the PALS training is facilitated and maybe even paid for people who need it, and it can be done in-house as opposed to people having to travel. The other thing I think that's very important, that across the country, often we collect metrics either on hand washing or what percentage our people have their courses, or med-rec, or ER transfer times, or experienced surge. Sometimes we collect metrics, and there's all sorts of other quality metrics that can be collected. And they get collected, and they go up to middle management, and then senior management, and then to the board in a dusty old report. And they don't always come back to frontline teams. So people don't feel engaged with it, and it's not sort of actionable. And I think that's a great shame, and I think we spend far too much time and energy on tons of metrics as opposed to picking a few key ones that we can really monitor and that really make a difference, and that we can share with frontline teams and ask them how they can improve things, because often the wisdom is there on the frontline team, but they do need the support from the senior management sometimes. Other things that we try to do, again, is early decisions if we have to transfer children, making sure that the equipment and drug carts are lined up. And I'll tell you, I sent one of my, actually he's a sick kids fellow in emergency medicine now, who came down to do an elective with us about last May. And I sent Dan around to all of our community hospitals around Cape Breton Island. I said, Dan, suppose there was a 3-year-old who had been burnt in a fire and had smoke inhalation and came into one of the community hospitals. How prepared are they, at least with the pediatric equipment and drugs? And he went around and found they were amazingly well prepared. But that was good to know, and because I didn't know the answer to that. We try to do mock codes. We try to have protocols that we share with our local children's hospitals, so we're doing things the same. Things like med-rec, also intrathecal chemotherapy. We've all heard of cases across the country and the world where vincristine was given intrathecally and the child died, and now we have systems where that's not given anywhere near when they get their intrathecal chemotherapy, or it's given in a bag as opposed to a syringe, and we try to force function it out. But those are lessons that we should be able to share and learn in real time if these never events happen, or serious adverse events happen. Could happen in a community hospital before it happens anywhere else with a new medication or a procedure or treatment, that it'd be nice to be able to share that quickly. And this is something I just have in my office. It's all about the team, the frontline team that's supported and getting better all the time and never being satisfied. And that's the end of my journey, Lisa.
Thanks very much. That was wonderful. Just going to hand the podium over to Dr. Apcon.
Thank you very much. Are you able to see our slides here?
Yeah, the slides look good.
Terrific. Well, I'm really pleased to participate in today's panel, and I enjoyed listening to Darlene and Trey and Andrew. I applaud CAPC's pushing a collaborative approach to safety. I think there's a lot of both power and safety in the numbers. I thought what I would do today is to address some of the considerations in driving safety at an organizational level. And I'll use some aspects of the Sick Kids journey that we recently launched to illustrate some of those things. And so we launched an effort this past year called Caring Safely with an intent of reducing preventable harm by 2/3, and I'm not over the course of 3 years. And I'm not going to go into a lot of detail about that. Trey actually covered a number of the elements of that, but I'll talk through some of the organizational issues that led us to launch this and that we're working through as we gain some momentum. So we've been working on safety at Sick Kids, as I know probably everybody on the in the audience has been for quite a long time, and we here have provided a level of local, national, and even international leadership in some areas related to safety, and yet we recognize through our own just paying attention and also some quantitative analysis that we still had some opportunities to reduce preventable harm still further. And there are a number of factors that led us to set a quantitative goal and to really kind of signal through bringing this together under one umbrella that we were taking a different approach. First, we've been trying to ramp up our general capabilities and focus on quality improvement in a very broad way. There's lots of things that we need to do through quality improvement to address other domains of the 6 domains of quality. But my own view is that safety is the most fundamental expectation for families that come to our organization for care, and that if staff see and if the public sees a lack of safety or threats to safety, then it erodes a real credibility around other QI efforts. People question, why are we putting so much effort on the patient experience, as an example, if we are having repetitive cases of some mistake that is potentially preventable and causing harm. So that's one factor. I think in terms of setting a clear target, 2/3 by 3 years, I have been personally swayed by Don Berwick's view on this, that some is not a number and soon is not a time. And that was the language that he used when the IHI launched their 100,000 Lives campaign. And from my view, I think we need to know how we're doing, and we need to know what kind of progress we're making, and without having some sort of a target in mind, it's very hard to do that. We also, I think, addressed the concerns within the organization around, boy, this is really complex. It's hard to get agreement on where to focus. It's hard to get agreement on the priorities. And it is complex, and we recognize that there are a number of challenges. But I think the issue is, how can we not start now? How can we not take the first step? And moreover, I think a focus on safety is a very effective organizing concept for bringing some of the considerations of high reliability thinking into an organization, because people sense the urgency. There's a high degree of credibility that these are important things to work on, and the tools are very generalizable. So we made the decision to bring this together under sort of one banner, adopt a set of tools. And there's a lot that we could focus on, but we have decided that very deliberately to focus on 2 types of preventable harm. One are what I would call the hospital-acquired conditions that we believe are potentially preventable given certain evidence-based practice adoption. So these would include things like falls and central line-associated bloodstream infections, surgical site infections, where we know that if certain practices are applied, you can markedly reduce the rate of these conditions. You may or may not yet know how to eliminate 100% of them, but we can markedly reduce them, and we can continue to learn through the study of these events how to prevent more and more of them. We've also, though, focused on what we are calling, and we've adopted this language from a number of other organizations, in particular the HPI group in the U.S. that's driven a lot of the thinking there around high reliability organizations, but this concept of serious safety events. And serious safety events are a way to focus the attention on those events where there is a clear deviation from an acceptable practice through either a choice or a mistake, and there is significant patient harm. So more than just inconvenience, but patients suffer permanent or temporary significant harm up to and including death. And these include things like diagnostic errors, delays in definitive treatment, errors in surgical decision-making, medical decision-making, technical misadventures, and those kind of things. And I think the language here is important because we need to have some grounding in the kinds of things that we're going to make priorities to try to prevent, and there needs to be a way to show with some general agreement that these are potentially preventable because there is a choice or a mistake, and we also need to show that they should create a sense of urgency through the harm that they create. And so it's been a way to focus, recognizing that there's thousands, if not tens of thousands, of near misses. There are many events that don't cause a lot of harm. There's few events, fortunately, that do cause a significant harm, and we have been trying to learn from those. We've set safety as a key priority. I will say it is a key priority. It's the first lens we should look at things through, but in all honesty, I don't think it can be the only objective or the number one objective at all costs. I honestly don't think that's credible, and I'll talk more about that as we move further. That's not to say that it's not the most important or the first lens we should use. Organizations set strategy. We have a strategy to be safe, but at the end of the day, that strategy depends on people being accountable for working safely, for adopting a way of working at the bedside or in the blunt end of the organization that respects the systems that have been put in place for safety, that are mindful of the risks in the work that they're doing, and to connect the dots between strategy, which a board and an executive team can do, but the accountability that frontline nurses, doctors, and other caregivers need to have. You need to connect the dots through appropriate policies and procedures, resources and investments in the right systems, measurement so that you can know where to focus for improvement, and skills around improvement. And it's an organizational responsibility to ensure that those dots are connected in an effective way. That without connecting those dots, I think that safety is more of a hope and a prayer than something that one can actually drive. So our lens within our organization is the lens of high reliability organizations, and both Trey and Andrew addressed that, and I won't go through the principles of that. But for me, safety is really about the combination of staying out of trouble or preventing accidents, and getting out of trouble or recovering quickly. And you can translate that to the concepts of reliability and resilience. And there's a formal program that we're adopting that helps to build reliability and resilience, and we can talk about that another time. I think we also are going into this with the perspective that failure is inevitable. No matter how much safer we get, and hopefully the rate of failure and safety events will go down significantly, but I think at some point failure is inevitable. But learning is optional. And the issue is learning may be optional, but it's an absolute requirement if we want to improve, if improvement is the target. And so we have built a set of processes that's intended to learn from failure so that we can close identified gaps one by one. I think one of the things that we recognize here, and I faced this in my last two organizations trying to lead some of the high reliability organization exercises or efforts, is that organizations create and need to manage a number of tensions as they go through this work. And a lot of the things that you kind of read in the high reliability literature and the things that you're supposed to do to promote reliability and resilience, people don't talk about what the consequences of that are as much as they probably need to. I mean, Trey mentioned the second victim. I think that is a pretty widely accepted one. But I will say that when I worked with consulting groups and kind of attended the lectures and tried to drive this, what they don't tell you about is all the things that come up along the way that actually can create some resistance or some organizational strain. And I think an important one is that failure feels bad. And when you're trying to learn from events, you're identifying events that were a failure and you're calling them as such, and you're relying on transparency to accelerate learning. But that transparency amplifies shame. And as Trey said, it may not be an issue of blame, but people blame themselves. You don't need to do anything organizationally to blame them. They feel it just by being caring caregivers that come to work wanting to do the best. And I think that can lead to a lot of what I would call comfort-seeking language and comfort-seeking behavior, sort of normalizing certain behaviors, not being willing to confront either behaviors or issues, versus being very deliberate, dispassionate, and approaching things from a problem-solving standpoint. And I think that one way to balance that is to make sure that you're celebrating excellence and successes more than the failures, because the failures will get quite a lot of discussion. I think the other thing is that not everyone's going to buy in at the same rate. You've got to recognize the safety people are pushing, and not everybody kind of gets it at the same time. When you teach people to find their voice and have appropriate assertion, it's going to create conflict, and you need to have conflict management as a part of this. I think the performance management, when you look at events and you look at choices that people make, you'll always identify normalized deviance, and then you got to figure out, is that an issue of individual performance, or is that a management and leadership failure? And then I guess the last thing is that there will always be competing priorities, and people are going to look at the decisions an organization makes and suggest that safety isn't really as important as you say it is, because you're not making the investments that they see as necessary. And I guess what I've come to realize that safety has, there's a couple of aspects. One is a short-term and a long-term view. And if we put all the resources into fixing a short-term problem, then the financial health of organizations and the integrity of organizations can be challenged over the long term and can compromise safety down the road. And I think there's another element of it, which is a narrow view versus a wide view, and putting resources in to fix one safety problem, for example, in an ICU at the expense of putting resources to address problems in the emergency department may make safety better in one place at the expense of someplace else. And I think it's an organization's responsibility to balance that short-term and long-term perspective, as well as that narrow versus broad view. And I think there's a lot of times when frontline caregivers need some help in seeing that. And I guess I would just say we spent a lot of time looking at what should be our target, and should we set something that's achievable, it's not going to disappoint people if we don't make it, and and I will say that I think there's only one credible target in the journey, which is to eliminate preventable harm, to get to zero. We can negotiate. We shouldn't negotiate the target, but we might have to negotiate the timeline. And I recognize that this journey, to paraphrase JFK, it may not happen in 100 days or in the course of any one administration or even our lifetime as safety experts. But the issue is, when are we going to start? Thank you.
Excellent. Thank you to Trey, Michael, and Andrew. So let us start then. We have two questions that we would like to pose to the audience and the members on the line today, and open up some dialogue. I recognize that we've got very limited time left, but let's open up some dialogue, and possibly we could actually even be continuing this into our webinars in the new year. So as we go back to the basics, as we heard from Trey about an informed, just culture and resilience, and certainly Andrew about the challenges that community hospitals have when they're looking at their safety agendas and safety issues, and then hearing about the caring safely from Mike and the decreasing harm by 2/3 in 3 years. So the questions for you, and positioning this in how can CAFC and the Patient Safety Collaborative, but the broader CAFC organization and community, how can we help you along this journey? So what we'd like you to consider are, what are your pediatric patient safety concerns, needs, or your advocacy priorities? And then how can CAFC be an enabler to building a patient safety culture throughout the continuum of care across the country of Canada? So that's the challenge of let us begin today. So Lisa, Lisa is going to be managing the either the questions that are being typed in or opening lines. So Lisa, I'm going to turn it over to you to see if there's any responses to the two questions that we're posing here.
We have some other questions that have come out of the audience. So Sharon is wondering, what do you think is the most critical thing that a senior executive officer can do to create a safety culture? What is a must-do?
It's Andrew here. If I can maybe take a quick stab at that. One thing I think is having training programs for physicians and their co-leads at the same time, if that doesn't occur in your particular institution, because to me that was the glaring opening, or the glaring hole in our institution, that people weren't literate in terms of some of the safety issues. That is, in terms of the physicians weren't literate. They all wanted to do well, but in terms of having the actual methodology or understanding, it wasn't there.
Great. And we have another question, another comment from Genevieve. On the topic of pediatric patient safety in the emergency room, in the U.S., there is a quality improvement initiative called the National Pediatric Readiness Project to ensure that all U.S. emergency departments have the guidelines and resources in place to provide effective emergency care to children. Could a program based on this model be applied here in Canada to help improve pediatric patient safety in community hospital emergency departments? And then the link to the National Pediatric Readiness Project is here, and I'll just post that link onto the Knowledge Exchange Network. Does anybody have any thoughts about that?
So this is Mike Alcon. I think that taking something like that on at a national level would have could have a very significant positive impact. We've done some examination of emergency department outcomes across Ontario, and the data is actually very interesting. So using provincial level data and looking at mortality rates across all emergency departments, community hospital and otherwise, there's quite a lot of variation in mortality rates. And there seems to be a pretty clear outcome volume relationship. And we kind of from the perspective of the Academic Health Science Center, I think we recognize it is very challenging for smaller and maybe even larger community hospitals to be able to do effective knowledge translation that's necessary to build capacity for safer pediatric care. Yet at the same time, more than 85% of pediatric emergency visits happen in that setting. And I think it's an opportunity for academic health science centers, which is really what most of the children's hospitals are, to help in a way that would maybe follow the kind of playbook that the U.S. hospitals are trying to follow. But I do think that there's a potentially a really important opportunity there.
Okay. And Mike, it's Elaine Orbine. Just very quickly to follow up on that, thank you for your response. Do you feel that understanding sort of the CAFC community and as Darlene has referred to us across the continuum of care, I'm hearing you say that emulating the National Pediatric Readiness Program in the U.S. might be something that we should consider.
Yeah, I mean, I always think it's good to look at choices in the context of what else, what else might you do or what else would you not do. But I do think that is potentially a very good opportunity, and the non-CAFC hospitals will have a very hard time getting there without the CAFC hospitals helping to develop that capacity and mentor them and kind of nurture the process along.
Okay. Very helpful. Thank you.
And I have another question from Sharon. Can CAFC be a place for discussion for great practices? Can CAFC work collaboratively with others like the Canadian Patient Safety Institute and ISMP Canada to help spread and innovate best practices? So on behalf of CAFC, I'll say yes, we've been doing that for a few years now. So I don't know, Elaine, if you wanted to comment a bit on that.
I so appreciate that question, and I couldn't echo more strongly. The answer to that is yes. Our knowledge translation platform is really foundational to all of CAFC's activities. So I think sharing best practices, learning from each other, and really, Andrew, you referred to that almost right at the beginning of today's webinar. So that is something that we should continue to talk about a little bit more as a group, as a collaborative, but not just talk about, maybe look at how we can really implement something very, very specific. I think that's another really, really good idea, and maybe one that could start, sooner than later kind of thing. And we do collaborate very closely with CPSI and ISMP Canada.
And I know we're at the top of our hour here, so we'll probably have to wrap up momentarily. But I just as sort of back to the emergency room question and comments. There is a TREC initiative, which sort of is a model for that, translating research in emergency care for kids. So there is a model, and we do actually collaborate with TREC as well. So these are things that I think that we have some groundwork, we have some things in place, and it's just to build it up a little bit more. So some really, really good ideas out there.
Fantastic idea. And I think that the advantage, and it's such a huge advantage that we have, is the CAFC Collaborative. Many of you online have been joining us every fourth Friday to be a decade now, or more than that perhaps. So I think we need to use the strengths in our collaboration, and I think we can take it the many steps further that our wonderful speakers this morning have sort of flagged some areas that we really need to address.
So we'll pass it back to Darlene to wrap up today. Darlene?
Darlene on mute, maybe?
Oh, sorry, I was. Sorry about that. So we didn't get to the questions that we had posed to you today, so that will be for another day, so stay tuned for that. I'd like to thank all three of the presenters for that today, for the information that they provided, which was wonderful and will be great food for thought as we move forward into a new year. And on behalf of the CAFC Patient Safety Collaborative, I'd like to wish everybody a very happy whatever celebration that they embark on at this time of year. And I'll just throw it over to Elaine Orbine to see if, Elaine, you would have any final closing sentiments that you'd like to add for us.
Thanks, Darlene. And first of all, if I may, Mike and Trey, Andrew and Darlene, and I will never forget Lisa, to the five of you, thank you so much for, I think, what everyone online has really felt to be a very important webinar today and a great learning. I think there are many new seeds that have been planted building on the work that we have done collaboratively for many years. I think we have many lenses. We have the community lens, we have the academic lens, and I think we can add the rehab and home care lens to that, because I know many of our colleagues online today represent that part of the continuum as well. I think what we have to find is something that is doable. And that was a point that Mike had made, and I think that's a very important aspect to keep in mind. We're going to keep these questions front and center, and if I could, on behalf of all of us online, on behalf of CAFC, if I could ask you to continue to think, you being all of our colleagues today, to continue to think about this and share your thoughts with us electronically, by telephone, email, doesn't matter how, and perhaps very soon in the new year, we can bring this right back to a more practical discussion now. And maybe Darlene and Lisa and I can do a little bit of thinking on the wonderful advice and recommendations that have been made on today's call by our content experts to put a bit of a framework together that we can share with you on the next call. At this point, on behalf of CAFC, on behalf of the CAFC board, best holiday wishes to everyone. And without your collaboration and leadership, and that's that collective leadership, we couldn't do what we do. So a heartfelt thank you to everyone. Happy holidays, everyone.
Same to you. Thank you, and bye, everyone.
Bye-bye.